firstly, I'm not going to go through the SBAs. Just to say, majority of you guys found it difficult. The pass rate wasn't great. So I think we need to look at reading more actively and in depth. I had a look at the questions and the breakdown of the marks, and I couldn't identify areas specifically where you went wrong. It was just generally, I think, poor knowledge of the theory. Generally, when we do these exams, the SBAs often have the lowest pass rate, mostly because those are based on theory. The OSCE itself is more practical, so you guys do better in the OSCE than the SBAs. But I think we need to look at how we read and how much we are reading every day, just to ensure that we are learning continually with regards to the theory. Okay, just want to see, I think 22 is sufficient. I'm going to go on to, were there any specific questions on the SBAs that I can answer before we go on to the written OSCE component? Any questions, any concerns? Okay, so I'm going to assume we were okay with that. So coming to the mock OSCE, so the written part of it, I'm going to look at the question and look at the answers for each. So one of the reasons, just going to wait for a few more people to join before I get into it. One of the reasons we do a mock OSCE is because of all the components of the exam, it is one of the most difficult. The reason being is it's composed of many different subjects, and every few minutes, well, 10 to 15 minutes, you sort of realign your whole thought process into an entirely new subject. So the idea is to help you to develop that skill and also time management. What I did notice when I was marking this is as we got towards the end of the paper, the writing became worse. There were more blanks that were left. So I'm not sure if this was just poor time management or whether the content was just not known. But I'm going to go with that it was just time management that was an issue for a lot of you. Also, when it comes to choosing which questions we set for this paper, I don't go and randomly choose topics from textbooks. These are based on talks that we would have had in the previous year, 6 months preferably. They're also based on grand rounds that would have happened during that time. So even if, say, you haven't gone through Eurogynae, you would have been exposed to this topic at some point during a Wednesday or a Friday morning meeting. So it's that you're not facing the unknown completely. So look at the first question was on first trimester aneuploidy screening. This was based on a talk given by Dr. Kumalo at the ONG update last year. There was also a Friday morning talk on fetal screening done by Dr. Frank. I think it was in November last year as well. So overall, you guys did well in this question. So I just want to open my mark so I can look at it properly. If I find it. And we look at the answers itself. One of the mistakes I picked up when looking at how you answered was for question B, when asked the criteria needs to be fulfilled prior to undertaking an NT scan some of you wrote the indications for an NT scan. So I think it's just interpretation of the question over there. And biomarkers, a lot of you wrote beta HCG. The correct answer is HCG because beta HCG is a component of the whole HCG molecule. But the correct answer for question D was alpha fetoprotein, estradiol, HCG, and inhibin A. Like I said, overall, we had a good response to this question. If at any time anybody has any questions, please speak up. I cannot see you if you raised your hand. If you have a question on anything, please stop me. Anybody? I'm going to take it as a no. This was question 2, and question 2 was based on a presentation done supervised by Dr. Jenica with renal disease in pregnancy. And this was a patient with pyelonephritis. So again, this was something that was covered during the previous year. When marking this question, one of the things I picked up was almost everybody got what the diagnosis was. It was acute pyelonephritis in pregnancy. But when mentioning 3 possible differential diagnoses, they'll also put down pyelonephritis. You can't have a diagnosis of a pyelonephritis and add the same thing under differential. You won't get any marks for that. Investigations were fairly standard. There were no issues. When we were looking at appropriate treatment for this case, there were 6 marks. The components that had to be mentioned was you would give the patient analgesia, IV fluids and antibiotics. And if you mention what analgesia you would give the patient, so paracetamol, which IV fluids you would use, which would be a crystalloid, and which antibiotics would be, so it'd be preferably ceftriaxone until you waited for your sensitivity to come back from the MCNS. Those would have given you 6 marks for question D. Any questions? Okay. So question 3 and 4 are related. So the first one, in question 3, was looking at definitions, and question 4 was interpretation. Both question 3 and 4 were based on Dr. Goldman's talk at the ONG update last year. It is also based on the latest NICE guidelines on CTG interpretation. When it came to definitions, there wasn't too much of an issue. So the first question when reading the CTG, what features need to be assessed? Almost everybody got the features there. But in addition, we wrote date, patient name, paper speed, history of patient. So that's not really features that you assess when you are assessing the fetal condition of looking at a CTG. Now, there's no negative marking, but when you're in an exam situation and don't have time, you're writing all those things, it takes away from the rest of the exam. So try and be more concise when answering the question. Maybe take extra time to look at the question and ask what they require from you. Also, what I noted was, even though we may know definitions, when it comes to exam situations, we tend to be more flustered because a few of the candidates, when it came to defining the deceleration, went as far as decline of the fetal heart rate by more than 15 beats per minute, but added each episode lasting 15 minutes. So I think that's more a stress-related mistake than you not knowing, but I'm sure you'll know it's 15 seconds and not 15 minutes. And yeah, that was about that for that question. When it came to the interpretation of the CTG, this was a little concerning. So the answers for that, what type of hypoxia is depicted above and why? And the answer would be it is acute hypoxia with prolonged deceleration lasting longer than 3 minutes. So majority of patients, candidates, were able to answer the first one. When it came to the cause, there were a few cord compressions, cord around neck, cardiac lesion, some said maternal cardiac lesions. But for something to cause an acute event, such as acute hypoxia, you have to have an acute cause. So acute causes would be a cord prolapse, uterine rupture, abruptio. Hyperstimulation can also be an acute cause, but that has to be sustained over time. But the three main causes will be cord prolapse, uterine rupture, and abruptio placenta. The management, I was a bit skeptical about people knowing the 3-minute rule, but I was pleasantly surprised by a few. If you do not go exactly with the 3-minute rule, but you went that you would diagnose and exclude the causes, if there was cord prolapse or an acute accident for immediate delivery, if there was no acute events, you would institute IPR, assess for imminent delivery. The marks were given, even if you did not time it according to the 3-minute rule, you'll receive those 6 marks. How does this affect the fetus? And that essentially drops the pH by 0.1 by every 10 minutes. That was a bit difficult, and majority did not know that. I did not know that. And the last question, everybody went emergency cesarean section. So the main areas where marks were lost was question B, what are the causes of acute hypoxia? Any questions? Okay. So question 5 essentially was a PPH question. This was based on a grand round done by Unit 2 last year. There were no major issues with this question. Everybody did well, I would say. Yep. Just again, I made a mistake over here in the answer B. The answer is uterine atony secondary to retained placenta. I forgot to change that. You see, I can also fail under stressful conditions. Risk factors, I had put down 3 grand multipara, previous PPH, previous retained placenta, but when I read through the scripts and marked them, the other risk factor that I did not put down was advanced maternal age, which is a risk factor, and it was accepted. Immediate steps and management. One of the steps was you were going to call the consultant. Remember, in a case like this, you are the consultant, but you can ask for a senior consultant to assist you. When it came to question D, almost everybody got to manual removal of placenta. Most did it in theater, but a lot of you stopped there. We sort of ignored the laparotomy part of it. If you failed removing the placenta manually, so laparotomy, trying to deliver the placenta via Caesar. Um, if you remove the sutures and the placenta and the uterus is still atonic, the use of compression sutures, and a hysterectomy if there's morbid adherence. So you went almost 2/3 of the way, but not all the way through. So that was it for the obstetric component. And everybody answered well. I think maybe again you'll have more time looking at these questions and able to answer. Are there any question or comments on the obstetric part before I move on to the gynae part of it? Hello, am I alone?
No, you're not.
Okay, you just don't have any questions. Okay, so if I can move on. Oh, there we go. So question 6 was a patient presenting with a history of amenorrhea and galactorrhea for 18 months duration. This question was submitted by Dr. Hira following Mahatma Gandhi's Grand Round presentation on a similar subject. We had utilized it for this exam. So broad classification of etiology for hyperprolactinemia. So the four classes would be pathological, secondary to pituitary tumors, lesions in pituitary hypothalamus renal failure, could be physiological, could be psychological, or it could be due to medication. So if you were able to identify those four classes and give examples, that were 8 marks. So what classes of prescribed medication can cause galactorrhea as a side effect? I can give examples. That's the whole list, but you only have to give me 2. The first one obviously was a given, dopamine receptor agonist. But this was something that people were able to answer. The rest of it was fine. For question E, a lot of you requested a CT brain. The correct answer is an MRI brain. But given that it's not readily available, I can understand why I would say a CT. But however, we have to mark according to the memo provided. And the correct answer was an MRI brain. This was one of the questions where there were a lot of blank areas, a lot of not even attempted any answers, and it's understandable you may not have read this part of your gynae, but it is something that you need to be aware of going into exams. Question 7 was supplied by Dr. Muzi Kumalo following his grand round on prolapse done last year. And the reason I had asked him to do this question was I thought he had taught it very well during the grand round, and I understood it much better than in my registrar days, and I hope that everybody else had also gotten the same benefit. When it came to the answers, I think people were a bit confused with the minus and plus signs. So if it's a minus sign, it means it's above the hymen, and if it's a plus sign, it means it's below. So generally, if they saw a minus, they meant the opposite way around. So those were the answers to the questions. It wasn't a well answered question. A lot of confusion lay in the interpretation of the results. And then when asked what compartment needs intervention, a lot of you put anterior, mid, and posterior compartments. You put all the compartments because you were not sure. Unfortunately, I cannot give your marks for that. And the potential pathologies are listed over there. Endometrial hyperplasia was a question. It wasn't actual presentation on its own, but it was covered during the presentation on use of progesterone in gynae. Of all the gynae questions, it was the question that was better answered, but still overall not well. So when it comes to the question of classifying endometrial hyperplasia, I know the classifications have changed over the years, but the one that's currently in use is the 2014 one by WHO, and it is classified as hyperplasia without atypia and atypical hyperplasia. So that would have given you 4 marks if you gave those two classifications. How do you make a diagnosis? Endometrial biopsy, any one outpatient papillary hysteroscopy and biopsy, and DD&C, any one of those would have given you 2 marks. If you wrote ultrasound, you would have received marks as well. Management of these patients. Back in my day, the Green Top Guideline 67, management of endometrial hyperplasia, had the best algorithm. It still does, and I will recommend that you all go and look at it. You can read the whole document. It is very informative when it comes to hyperplasia, but it's all very well summarized in the algorithm where you look at if you have endometrial hyperplasia without atypia, how to assess the patient, management, when to do your endometrial biopsies. So if just endometrial hyperplasia without atypia, you repeat endometrial biopsy at 6 months. If it's atypical hyperplasia and the patient declines or is not suitable for surgery, then you will do your endometrial sampling at 3 months. If there is a regression, you can review your treatment and decide how long to continue or stop. And you can still offer hysterectomy even in the presence of regression of disease. Persistent disease, you can either escalate your treatment or you would advise a hysterectomy. If there's progression of disease, then the patient should be recommended that they have a hysterectomy. If they continue to have regressive histology or repeat biopsies, you do a range follow-up according to what it is mentioned here. If the BMI is less than 35, they have 2 consecutive negative endometrial biopsies at 6-month intervals, then you discharge. But if BMI more than 35, you need to continually do endometrial biopsies annually and review as these patients at higher risk of relapse. If a patient relapses, you advise a hysterectomy for these patients. I went through this a bit fast, but I would please go and have a look at this algorithm. These are freely available online. A few candidates mentioned ablative therapy as part of your management, but it is not recommended due to the risk of formation of synechia in the endometrium, which cause closure of your cavity, and therefore you are unable to sample the endometrial further for surveillance. So ablative therapy is not an option when treating endometrial hyperplasia. So the last question, looking at UDS, this was based on talk done by Dr. Mile. He essentially did surgical management of stress incontinence, but I did touch on UDS as one of your investigations. And again, there were a lot of blank answer sheets. I understand a lot of people now have gone through a urogyne and may not have been exposed to this, so it would be difficult. But overall, again, this was a poorly answered question. One recommendation I can make if you do not know the answer, try something. Treatment modalities. If you didn't answer A, B, and C, if you wrote a few things on treatment modalities, like counseling the patient, avoiding coffee, pelvic floor exercises. If you wrote to give the patient oxybutynin or Botox injections, you would have gotten a few marks instead of just leaving it blank. So there's no negative marking. You can attempt, and if you get it wrong, it's wrong, but a few marks always helps either way. So that's the last part of my bit. Are there any questions on a whole overall? So what I will do is when the feedback is over, once Dr. Mold has completed his part, I will send everybody their marks. The papers, the last time I scanned and sent, but that took a long while, it was a bit difficult. So what I'm going to do is I'm going to recompile them and give them to Grace. And if y'all can pick up your scripts from Grace, that would be great. Okay. I'm going to stop here now. Dr. Mold, are you on?
Yeah, I'm here.
Okay.
So I'm just going to get my screen sharing going.
Sure. Thank you.
All right, so I'm going to be running through the section on the oral component of the exam. It was just 3 questions, and because of time constraints, they were limited to 8 minutes. Obviously, in your college exams, these are 15-minute questions. And so what we did was we tried to compress an OSCE type question into a shorter time scale by omitting some of the components. But we try to keep it as realistic as possible. Having said that, the one we start with is the one on Mirena. And this was largely a theoretical question. In other words, if you knew your theory, you would have done very well on this question. So just to note that not too many people knew about the existence of the lower dose Carlina, which is the smaller version of Mirena, which is available. And there's 19.5 milligrams of levonorgestrel in the smaller Carlina device, and then the 52 milligrams of levonorgestrel in the standard Mirena. Just to note that the efficacy of the Mirena is around, you have a failure rate of about 0.2%. And so a number of people underestimated that efficiency or efficacy rate of the Mirena. In terms of the interval that you can leave the Mirena in for, we know that the FDA has increased the Mirena up to 8 years, but in South Africa, it's still quoted as being 5 years. So we would have accepted either 5 years or 8 years. Remember that anovulation is not the primary aim of Mirena. Only about 60% of patients on Mirena are anovulatory. In fact, 60% of patients will ovulate on Mirena, but 40% are anovulatory. So the main effect is really that of the local progesterone effect on the endometrium and the cervical mucus. In terms of how the Mirena differs from the Carlina. The question was how that difference is manifested when the device is in situ. So obviously there's not a lot to go on. But when you visualize the strings on speculum, the Carlina has got the blue strings, the Mirena the brown strings, and then on X-ray or ultrasound, you can actually see a ring on the base of the Carlina. The examiner's feedback on this was that there was generally not a high level of clarity on exactly how to insert the Mirena. Obviously, it differs from the standard intrauterine contraceptive device. And so it really does require you to have had hands-on experience with it. The package insert for Mirena is very helpful. If you just have a look at that, it really does assist you in understanding exactly how to insert one. So this was a family planning question, probably not entirely typical of the type of question you would get in an OSCE because it's a little short for a standard OSCE question, but it was very helpful in terms of testing people's understanding of how to insert a Mirena and testing their in-depth knowledge. And a lot of this kind of knowledge that was asked here could well come out in an SBA format in an exam scenario. Any questions so far? Right. So we'll switch over to the next one. This one was the one obstetric question. And at first glance, you might miss the very elevated blood glucose on this patient. I'm told by the examiners that that wasn't really a big issue. Most people did recognize that this was a DKA.
Dr. Mo,
yeah.
you're still showing question 1.
Oh, let me try this again.
You'll have to cancel this share.
Happy?
Yeah. There we go.
Thanks. Yeah, so this was obviously the question vignette pointed towards the fact that this lady had some form of infection and likely to be a respiratory tract infection, but you had to be fairly sharp to recognize that she had obviously a very elevated blood glucose. The initial version of this question had the patient being in her earlier teens, sort of 16 or 17-year-old, but and that obviously would have raised a whole lot of other issues that you would have had to discuss, but certainly in 8 minutes that was never going to be feasible. So we just trimmed the question a little and made her 19 years old. The history, obviously, and examination for a part 2 question is never going to be the biggest component. It's increasingly with the part 2, we're moving towards giving you quite a comprehensive vignette in terms of giving you the information that we want you to know. So the emphasis has shifted away from history taking and examination, which we'd assume was done well at an undergraduate level, and more towards management. So the history taking needs to be very focused, and the feedback I got was that people were not focused enough in their history taking. You need to move swiftly and logically through your history so that you can get onto the management component of the question. And so, you know, there's really no marks in a part 2 for asking things which are routine and have no bearing on making a diagnosis. We really want to drill down to those things which are key to the diagnosis in this patient. Likewise with the examination, not a big mark allocation, and really just the key elements that are going to make a difference to your management of this patient. So as the candidate went along, they were given information. in this case, the information didn't change your trajectory very much. It's kind of what you expected. But you were told that on dipstick she had 2+ ketones, and that your clinical findings were in keeping with a patient who had a family history of diabetes and were compatible with a low respiratory tract infection. Lab investigations, they are there for you to see. Nothing untoward there. Just remember COVID, which we all seem to have forgotten about in the last year or two, and obviously to investigate for an underlying cause for the lower respiratory tract infection. Again, the investigations here are not unexpected, but we do see that this is a lady who has poorly controlled diabetes as a result of, as we can draw that conclusion from the HbA1c. We see that she has elevated infective markers, suggesting an infective process, probably bacterial in origin, given the procalcitonin, and that she is acidotic. And with really, guys, we need to be able to interpret blood gases. Remember that the pH gives us the primary problem. We can see that she's acidotic, and therefore the primary problem is acidosis, and then we can see that the PCO2 is moving in the opposite direction, i.e. she's had a compensatory respiratory alkalosis. So low bicarb indicating that it's primarily a metabolic issue, and then compensatory respiratory alkalosis. Now, the majority of the marks on this question were allocated towards the management, and the obstetric guys were indicated that they felt the problem with which we have is that quite often these patients are handed over to the physicians to be managed, and that means that we ourselves don't have the detailed knowledge of how to manage each component. So quite a lot of candidates gave the principles, but they didn't have the details. And so this is where people fell down. Obviously, there is some flexibility in terms of exactly which protocol you use for fluid management and insulin management. But the ones that are given here are the ones that are used here at Otuli and are standardized management protocols for the diabetic patient. And then just remember that we needed to just monitor the fetus as well. There was, again, in this question, an original component which talked about more of the long-term management, but in 35 minutes, in 35 marks and 8 minutes, it wasn't going to be feasible. Any questions on this one? Right. Again, we're back to an applied question here, one where you're given a fairly comprehensive vignette, another gynae question. And here we are told most of the history that we need to know. And so the question omits the need to take a history. As I said, this is a fairly typical format for what you're going to see. It'll give you quite a clear clinical picture of what's going on, and then it'll give you some specifics about the direction you should be taking as you spend your time looking at the question. This was a question where you had to have the skill to respond to the information given to you and then alter your management accordingly. So the problem that people had with this question was that they had kind of set themselves on a trajectory based on what they saw on the vignette, and then they struggled to change direction when given the information. given information that they didn't necessarily expect. So just to note that you need to think about a differential up front here with this patient, and then base your examination around that differential. Look at the specifics that will help you to differentiate one from another diagnosis on differential, and that's where the marks will be found. Nothing unusual on the examination of this patient, other than the fact that we don't see an ectocervical lesion. So this is not a straightforward squamous cell carcinoma of the cervix. This is something else that's going on here. Slightly what we would call a bulky uterus, too big to be called normal, but not big enough to be palpated abdominally. And the vignette gives us a few hints back here to say that this is a lady who had issues with dysmenorrhea and menorrhagia prior to menopause. So we needed to just bear that in mind as we considered her possible diagnoses. So we see effectively a lady who's just got a bit of bleeding from the os, but nothing else besides the slightly enlarged uterus. Investigation is very straightforward, nothing. And I would imagine that nobody had difficulty with that. What we see on ultrasound is a globular uterus, a uterus that's it has the same dimensions AP as it does in length. So that is a fairly characteristic appearance of a patient with adenomyosis. And then added to that, we see that she has this inhomogeneous appearance of the myometrium. So your differential here was that this was something that was pre-existent, or it was related to the current postmenopausal bleeding problem. The PAP showed atypical glandular cells, and Papel showed an adenocarcinoma. Now, for the student who's on the ball, it's good to know the immunohistochemistry, which enables you to differentiate endometrial from cervical carcinoma. It's pretty simple. Endometrial carcinoma will express estrogen and progesterone, as well as vimentin. And then your typical marker for cervix is P16. And so in this case, this adenocarcinoma was P16 positive, but negative for all of the endometrial markers. But we were not too worried about the immunohistochemistry, because the examiner would have told you that the histology suggested cervical origin, which typically is what you will see on a histology result. The problem is that I think people fail to recognize that when you do a Papel, you don't only typically sample the endometrium, but quite often you sample the endocervix as well. And so it's quite possible that you'll pick up endocervical sampling in the process of doing a Papel. So people were fixed, I think, on the idea that this was a endometrial carcinoma, and when they were in fact overtly told it was endocervical, they still struggled to then shift gears and recognize that this was a cervical carcinoma. In terms of the adenomyosis, as I say, very likely that this was an endocervical carcinoma with a pre-existent adenomyosis, but it isn't impossible that there was spread from the endocervical carcinoma into the uterine body, which might have accounted for that. So if you said that, we wouldn't be happy about that answer. This was done poorly. For some reason, people were very hazy on the idea that you simply needed to do a standard cervical carcinoma workup for this patient. You've been given the diagnosis, and now you simply have to exclude distance spread, the usual chest X-ray and ultrasound, obviously establish where she is in terms of HIV, basic bloods, and then because this was clinically an early endometrial endocervical carcinoma, you would have then been sitting with a dilemma as to whether you opt for a surgical or a oncological approach, in other words, surgery or radiotherapy for this patient. In the absence of MRI, you would do a careful clinical examination of this patient, and if you felt that there was no parametrial spread clinically, it would be justifiable to go ahead and offer her a radical hysterectomy, provided that you noted that all of your other investigations showed no distant spread. But obviously, ideally, you'd want to do an MRI on this patient to establish this was, in fact, a stage 1B2 or less, and that she was suitable for a radical hysterectomy. So yeah, their management was simply either radical hysterectomy or concurrent chemoradiotherapy for this patient because of a cervical carcinoma. So, any questions on the orals?
Ramon Bolt.
Hi.
Yes, yeah, I see in investigations that you put MRI, one would put pelvis, so you end up getting confused when really should choose MRI or when should we do a CT scan. Even the other case by Dr. Maharaj, that hyperprolactinemia, some posts will prefer you do a CT brain, some MRI, so you end up getting confused to choose the wrong investigations.
Sure. So, I mean, the literature will talk about a CT scan for patients with CS cervix. It doesn't help very much in terms of delineating the local pelvic lesion, but it does tell us a bit about the lymphadenopathy, the pelvic and periaortic lymphadenopathy. But in our local setting, we don't use that. So we don't really do any CT imaging for CS cervix, other than in unusual circumstances like patients who present with coexistent adnexal masses. So there's generally not much of a place for CT scanning in CS cervix. We really do select out those patients where MRI is going to make a material difference to our decision to do surgery. So we, on the whole, it's a clinical staging with very basic investigations to exclude distance spread. But that small subset of patients where we're considering radical surgery, they do benefit from MRI, but almost, yeah, we really just don't do CT scan. So yeah, I agree with you. You will see CT scan mentioned in some of the literature, but in our local context, we don't use it, and so yeah, you really don't need to go there in an exam.
Okay, thanks, Dr. Bolt.
Right. I don't know if Tisha has any further comments in general.
Not from my side specifically, no. Thank you.
All
But
right,
just
thanks.
to encourage people to, attempt the OSCE. There are candidates, registrars, sorry, who have reached their third and fourth years and have never attempted OSCE, a mock exam. So, like I had mentioned at the beginning, it is to help you train yourself to, when it comes to the actual exam. And if you don't make it, it's not the end of the world as such. excuse me, when I wrote my first OSCE, I failed the mock exam. The second one, I failed again. I failed better, but I failed. And the third one, I passed, and the rest is history. But the whole point of this exam is to help you prepare for the final exam. So I see there are candidates on here who are planning to write exams, but did not attempt this OSCE here. But please do try. This exam is for you. It's not really for us. And it's not something we gossip about over tea or what who did what and how they answered this. This is all to help you guys in your final exams. That's it from me. Thank you.
Yeah, nothing further from me. I think Atisha said it well. Thanks, guys. Yeah, that's it.
Thank you. Have a good day.
Thank
Thank
you.
you very
Thank
much.
you.
Bye.